El primer doctor lo va a presentar ahora mismo. Venga.
Bueno, tenemos tres expertos y maravillosos ponentes. El primero de ellos nos ha concedido que le presentemos en castellano el doctor Michel Molina, profesor de la Unidad de París, jefe del Departamento de Enfermedades Infecciosas del Hospital de San Luis en París. Tiene una amplísima experiencia en el manejo y el tratamiento de la infección por VIH, una cohorte de más de 3.500 pacientes y, como sabéis, tiene una amplísima experiencia. Ha sido investigador principal de algunos de los ensayos clínicos más importantes en profilaxis preexposición. Así pues, le damos paso. Doctor Molina, please, you can.
Muchas gracias. Buenos días a todos. I'll switch to English now. So I've been asked to talk about the pitfalls of PrEP, and let me tell you that it's an honor to be invited to speak at this Guerriza conference, and I'm very pleased to be here in Spain with a lot of friends in the audience, and again, it's a pleasure to talk about PrEP. So I'll start with my disclosures, and also with these good news from Paris and France, because for the first time in the last 10 years, we've seen between 2015 and 2018 a decrease by 16% of the new diagnosis of HIV, and this decrease is only seen among MSM born in France, those who have access to PrEP, a 28% decrease in Paris, and these data have been presented at EACS earlier this year. We have also similar results for France overall, and I think that's the evidence that PrEP not only works to prevent HIV infection at the individual level, but that it also have a public health impact. And I'm very pleased to know that in Spain now, PrEP has been approved and is available, and that you will be more and more involved in PrEP delivery. When we talk about PrEP efficacy in the real world, I like to present these data from Australia in the large demonstration project called EPIC, in which they provided PrEP to more than 3,000 people. And when they looked at the incidence of HIV in the cohort, as you can see here, it was very low, less than 0.05 per 100 person years of follow-up. And there were only 2 new HIV infections in the cohort. One in an individual who was dispensed PrEP but never started his medication, and the other one who actually discontinued PrEP a couple of months before being infected. And when we talk about the causes of PrEP failures, I like to use this definition that Julia Marcus proposed, that PrEP failures are defined as any HIV infection that occur at any point along the PrEP continuum of care. And what I'm going to try to do today is to look at the different steps where PrEP failures can occur. It could be because of the user's failure to take PrEP, because of the system, because of the healthcare providers, because of the assay we're using, and because of the drugs that we're using for PrEP. So let's start with the user failures. This is a study conducted in Atlanta and published by David Serora in CID, where they looked at 300 young black MSM, and they were trying to look at HIV and STI incidence, and they provided PrEP to those individuals free of charge. And then they looked at HIV incidence during follow-up. Interestingly, only 50% attended the first PrEP initiation visit and were given a prescription. And when you look at the incidence in this cohort, it was very high, 6%. And you can see that among these 14 incidence HIV diagnoses, 10 actually were seen in people who expressed either no interest of PrEP, and in those having expressed interest but failed to start PrEP. And in those who started PrEP, there were also a few HIV diagnoses. One, this case here, where PrEP was not enough to prevent HIV infection, but the HIV infection was diagnosed at the first visit after PrEP initiation, and it's likely that this guy had undiagnosed acute HIV infection. The second case here was in a patient who had low adherence to PrEP, and these 2 additional cases here in people who discontinue PrEP. So it is critical to monitor PrEP in those starting PrEP, and that's why we have to see patients every 3 months and to reinforce adherence, because that's not enough to start PrEP. The challenge now is to maintain people on PrEP. When we looked at the data from the US, and this is a large data set from the Kaiser Permanente cohort in people who were referred for PrEP between 2012 and 2017, more than 7,000 people. And you could see that at the first visit, 26 individuals were diagnosed with HIV, and we know that when PrEP is available, we can actually see people at high risk with a new HIV diagnosis, and that's a way to address the what we call the hidden HIV epidemic. Also, interestingly, 30% of these individuals who did not start PrEP, they had a pretty high incidence of HIV, 1 per 100 person years of follow-up in that study. In the 70% of people who started PrEP, there was no HIV infection during PrEP use, and that's also good evidence that PrEP works very well. Again, we have to be aware of that among those who discontinue PrEP, 26% at some point, the HIV incidence in these individuals was also very high. So people, when they stop PrEP, they are still at high risk of becoming HIV infected if they are not using condoms. And this is something we have to deal with. Let's look now at what we may call system failures, when there is lack or limited access to PrEP for high-risk individuals because PrEP is not approved, because it's not subsidized. But I think the main issue now is the lack of awareness of people at risk that PrEP exists. And now that you have PrEP available in Spain, I think the main challenge is to make people at risk aware that we have a new tool to prevent HIV infection. Let's look again at the data from the US. If we looked at the prescription of PrEP in the US between 2014 and 2016, nearly 100,000 people were using PrEP in 2016. But you see that the vast majority were male, and only 6% of PrEP users were women, and this covers only 2% of women in need of PrEP. If we look at the data from men, you could see that 69% were white, and only 11% were actually black, but black represent nearly 40% of the new HIV diagnosis in the US. So clearly, there is a gap here that we need to fill in the future. Let's look at what we may call healthcare provider failures, when there are missed opportunities by healthcare providers to prescribe PrEP. And these are data from Smith and colleagues from the CDC, where they looked at more than 800 new HIV diagnoses in South Carolina, and they found out that 66% of these persons had a mean of nearly 7 visits to a doctor prior to HIV diagnosis, and at no point these people were proposed to use PrEP or to start PrEP. And these individuals were mainly female, black, and less than 30 years of age. And they went mostly to the emergency room and also to their primary care doctor. So we clearly need to increase knowledge about PrEP among people at risk, among physicians, and improve their training to prescribe PrEP, to address the reluctance to prescribe PrEP. Some moral issues may still remain here. And we clearly need to integrate PrEP in healthcare services, and also to rely on community-based PrEP delivery in setting where it is possible to do that. Of course, now we have also to deal with challenges with the HIV diagnostic test we have in people starting PrEP, because we need to first rule out acute HIV infection. We need to know how to diagnose HIV infection in people on PrEP, and manage what is emerging is some case of false positive tests in people on PrEP, which are actually quite stressful. You've seen that before in the oral session, the sequential appearance of viral markers, and I'd just like to point out that after infection, there is an eclipse period of 11 days where no viral load is detectable, even using PCR. And it needs 6 additional days for the GAG P24 antigen to be detected. When we looked at the IPERGAY study and we tried to assess the performance of different HIV screening tests in those with HIV diagnosis during the IPERGAY study, when we looked at people with a complete Western blot, it was clear that all tests were positive, whether you use the 4th generation combined antigen antibody assay or any other rapid test. But if we focus on those with a negative Western blot, with really acute HIV infection during the study, you could see that the oral test performed very poorly because their sensitivity is not high enough, even if you look at the combined antigen antibody assay from earlier, the new rapid test. But again, even using serum with the Architect combined assay, 4th generation assay, we are missing 15% of the cases. And the 2 cases that we've missed were diagnosed retrospectively using the biobank, and we were able to show in these 2 cases very low viral load, 110 copies or 450 copies. So there's, it's clear that even with the 4th generation assay, you can miss acute HIV infection. In that study done by D'Souza in Thailand, they looked at the performance of the combined HIV antigen antibody test to diagnose acute HIV infection. So they used rapid test first to screen more than 70,000 people at risk for HIV. They found a pretty high prevalence of 10% using rapid test, and then they screened this individual first with the combined HIV antigen antibody assay. They found 81 additional people with acute HIV infection, and when they repeated the test 2 to 5 days later, again, 8 more individuals. So they were eventually able to diagnose 70% of the total of acute HIV infection, because those who were negative were then tested by pool HIV RNA, and they detected an additional 31 individuals with a median viral load that was quite low. The range is from 82 copies to 80,000 copies. And so that's why the CDC, in their guidelines to determine the HIV status before starting PrEP, they recommend to use an HIV immunoassay first, and if it's negative or indeterminate, and if there are no sign of symptom of acute HIV infection, now you could consider that your patient is HIV negative. If there are sign of symptom of acute HIV infection, they recommend to use a combined HIV antigen antibody assay, or to screen for HIV viral load, or to retest antibody 1 month later, and to defer PrEP. Unfortunately, and we know that from that study from Rob and al. In East Africa and Thailand, not all people with acute HIV infection, especially if you are diagnosing acute HIV infection early enough, have symptoms. And in that study, 71% of participants had no symptoms. That's why the guidelines from the IAS, USA, and French guidelines differ. We recommend to use in all individuals 4th generation antibody antigen assay. And if there is a high risk of acute HIV infection, we recommend to use, in addition, a PCR to detect acute HIV infection. And in any case, we do not recommend to defer PrEP, but to start PrEP, but to do another test 1 month later to diagnose acute HIV infection, which could have been missed by these at the first visit. What is the impact now of PrEP to diagnose HIV infection with the assay we have? And this is a study done in Partners PrEP in Africa, where they looked retrospectively at the timing of HIV diagnosis at the site in people who received placebo in red, and those who received PrEP and who had actually tenofovir in their plasma. So these people were really taking PrEP. And you can see that there is a significant delay in the time for detection of HIV infection when people were receiving PrEP. And also in that study, what was interesting to see that when PrEP was diagnosed, the level of HIV RNA in plasma was lower in those using PrEP. This is probably not surprising, with a difference in 0.6 log. And also when you look at all the tests that were done, 11% in those on PrEP versus 3% in those on placebo had undetectable plasma HIV RNA at the time of HIV infection. What was reassuring in that study was that using the Architect combined assay, there was no difference in the signal to cutoff ratio at any stage between the two groups. But this is a case, and I'm going to show you a couple of cases like that, where you can see we have challenges to know what's going on in these people. This is a 31 gay man on PrEP for a year. He was tested negative with an HIV combo assay. He has excellent adherence to PrEP, and he was kind enough to participate to a study to evaluate the performance of point-of-care tests to diagnose HIV infection while on PrEP. And he got at day 0 here a first test using the HIV combo allele test, the one I just presented a few slides ago. And unfortunately, at that time, the test was positive, and positive for the antigen. Antibody negative. The other tests that was done at that time were negative. Here, another antibody point-of-care test. The HIV 1-2 supplemental assay was negative. The viral load was undetectable, but still, clearly these patients and the team also was concerned that this guy had acute HIV infection despite the use of PrEP, and repeatedly over the next couple of days, and you see that goes up to day 70, the tests were repeated because people were not sure these guys were infected or not with HIV. And you could see that over time, the antigen remained positive, antibodies always negative. Here, the combined assays sometimes indeterminate, but the viral load always negative. And so eventually it was concluded that this guy has a false positive antigen assay. And it's quite difficult to manage these ambiguous HIV test results during PrEP, and that's why there are some guidelines that can help to see what to do. And clearly what's a challenge is to confirm the presence or absence of infection. So I guess the best way would be to repeat the test, to do RNA tests. The DNA tests are not yet validated to diagnose HIV infection in adults. They are in infants. I think it's also very important to use other tests from other manufacturers and to manage the use of antiretroviral drugs in these people, and of course to ask them maybe to be careful about their sexual intercourse. So I think there are 3 main situations. If the patient has good adherence to PrEP, the likelihood of breakthrough infection is very low. So I think you can continue PrEP, but of course there is a potential risk for resistance to HIV if these people is indeed infected. If this guy is not adherent to PrEP, then there is potentially a high risk of clearly breakthrough infection. In that case, you may consider starting combined ERT, but then the challenge is how to confirm HIV diagnosis and what about the drug-related adverse events. So our preference right now is to stop PrEP and reassess HIV status of PrEP, although in this case you have to be careful about the risk of catching HIV through sexual intercourse, and this guy should be clearly using condoms, because although this will facilitate the diagnosis of HIV infection, there is a risk of infection during this period of PrEP. And clearly we need more experience to know how to manage these results. You need to repeat testing, to discuss with your colleagues, the clinician, virologist, pharmacologist, seek expert opinion. And in the US, they even have a toll-free line to discuss these cases. And I think that's a good idea to have these free lines in each country to be able to know what to do. This is a case we've seen in our clinic, in a person using on-demand PrEP with TDF-FTC for a couple of years. High adherence, always negative. Last negative test in March of 2018. And then he went to another lab to have his test done before the visit with another test, and then the test came back positive. The Western blot was negative, but this guy was quite alarmed. He came to their clinic. The first test was repeated at the clinic. He was also slightly positive with the architects. You can see here the index was 1.5, so very low index, but still positive. We did another test with a Bioplex assay, was negative. The Western blot was positive with a single band, P24, HIV RNA negative. So again, there was a possibility that this guy had acute HIV infection. So we decided to stop PrEP. We measured drug level, tenofovir, to make sure that PrEP was really discontinued. And you can see that over the next 30 days, this guy was retested off PrEP, no tenofovir, so he clearly discontinued PrEP. The architect remained positive, but you can see that the index did not increase. The bioplex remained negative. The Western blot still positive for P24, but no additional bands. HIV RNA always negative. So when we look at the Western blot here, you can see that these faint bands remain, but no additional bands appeared. So we were quite confident that this guy had no acute HIV infection. This was possibly a false positive test, and we told him you can, resume PrEP. But this guy was too anxious, and actually it took him 7 months to be able to be sure he was not infected and to resume PrEP. And you can see that at month 7, the architects were still positive, and the P24 antigen band remained also positive. So these cases are rare, but it's good that you are aware of these cases to know how to handle these cases. And when you say you have to wait for a month before starting PrEP, I think we're not sure how long we need to wait. And if you look at this data from Don Colby from the CDC in Thailand, in people who have started ART at the time of acute HIV infection, when they stop ART, they looked at the time for rebounding HIV RNA, and you could see that in median that was 26 days, but in some individuals it could take up to 8 weeks, and there are other cases where it could take more than that. So we're not fully sure that a month is enough off PrEP to rule out acute HIV infection. Another challenge, of course, is what about the people that could be infected with viruses already resistant to tenofovir and FTC? We have in the literature so far only 5 cases reported in these slides. But I think when you look closely at each of these cases, I think they are not very convincing that this is actually HIV acquired with a resistant virus despite the use of PrEP. If you look at this case, for example, this patient was seen only 14 months after the first visit, so there was not interim visit. And the first visit, he received PrEP for only 11 months. So he had not enough PrEP to cover actually 14 months. And I think although adherence to PrEP was good, in the few weeks before diagnosis, we're quite sure that this guy at some point ran out of PrEP. So he may have acquired HIV infection during that period. In that case here, again, the virus at the time of HIV infection carried the M184V mutation, but this was the first visit after PrEP initiation, and at PrEP initiation there was no RNA, there was no 4th generation assay, so we are not sure this guy was not already infected. And if we want to know what's the impact of the M184V mutation on the efficacy of PrEP with TDF-FTC, it's good to look at data from macaque model. And we know in vitro that when you have this mutation, you have high resistance to 3TC, but the virus is hyper-susceptible to tenofovir. So when they looked in the macaque challenge, our colleagues from CDC, they inoculated these macaques through the rectal route, and in the control macaques with no PrEP, all macaques became infected. In those on oral TDF-FTC given before and after the challenge, there was no HIV infection. So clearly, in the macaque model, despite this M184V mutation, the efficacy is complete. They also looked at the other mutation, Ki65R. This mutation is a little bit more tricky because it affects both in vitro FTC and TDF. And although it was more difficult to do these experiments because they had to increase the infectivity tenfold as compared to a wild-type virus, they were eventually able to infect all control macaques. When they looked at the macaques who received TDF-FTC, the efficacy here was much lower, only 33% efficacy. So clearly, K65R might affect the efficacy of PrEP in people exposed to a virus with this mutation. But if we look now at the rate of transmitted HIV resistant to TDF-FTC among treatment-naive patients, and these are 5 different cohorts with a lot of patients, as you can see, and you look at the prevalence of K65R in this population, you can see that it ranges between 0.1% to 0.03%. And I looked at the recent data from Spain, only 2 cases of K65R were actually seen in those with recent infection or before starting PrEP. So this is a very rare event, people exposed to viruses carrying the K65R mutation. What's even more troublesome is this case report from our colleagues in the Lancet HIV in the Amsterdam cohort, where they report the case of HIV acquisition in someone on PrEP, but who acquired a virus with no resistant mutation, susceptible to TDF-FTC. So this is a 50-year-old MSM who started daily PrEP. These guys, as you can see, had condom-less sex with a lot of partners per month, between 12 and 75 partners every month. So he had multiple STIs. HIV tests were always negative, but at month 8 after starting PrEP, he got fever, an E. coli UTI, anal LGV, and at another site, and they did, and that was right, an HIV test. The HIV test was positive using a 4th generation test. This guy had high adherence to PrEP, 7 pills per week. When you looked at tenofovir diphosphate level in dry blood plots, they were consistent with daily use. So this guy clearly was adherent to PrEP. He went back to his sites for PrEP. They repeated the 4G test. It was again positive. There was a negative antigen, but the Western blot was positive for the GP160 band. There were no HIV RNA in plasma. They looked at PBMC. They looked at DNA in PBMC. They looked at DNA in sigmoid biopsies. There were no virus at all. So what they did, they stopped PrEP here. The patient was seen a week later. The results were the same. No viral load. The Western blot, as you can see here, you had the Western blot on May 24, just a faint band, GP160. The guy was seen again at June 15, and at that time the viral load was detectable for the first time. You can see the Western blot, July 18, June 33, no additional bands. At that time, the viral load was quite high. So it was clear that this guy was infected with HIV. And you have to wait until July 18 to see additional bands in the Western blot. So what happened here? Is it the consequence of a high inoculum effect which actually overcome the efficacy of PrEP? Is it because of concomitant LGV infection? Is it because this guy was not adherent at some point with PrEP and this was not detected by what we call cumulative adherence markers? Is it because of variable PK distribution of TDF-FTC in blood or rectal mucosa? A combination of all of the above? I think there is another explanation in that case, is that this guy was infected with HIV after PrEP discontinuation. Because although he reported condom use with all these partners, this guy who had a median of 30 partners per month, maybe he didn't use condoms consistently and was infected with HIV after PrEP discontinuation, and he had actually a false positive Western blot initially. Another challenge is the risk of resistance in people infected with HIV despite the use of PrEP. And these slides from Parikh and Mellos summarizes a number of trials, all randomized trials, placebo versus TDF-FTC, where they looked at resistant mutation for either FTC, M184V, or TDF, K65R, or K70E. And all mutations that were reported were M184V, except one single case of K65R. And when you look at the timing of these mutations, you can see that the majority of these mutations were seen in individuals actually who had acute HIV infection when they started PrEP. So it's clear that if you start PrEP with TDF-FTC or dual combination in someone with acute HIV infection, you're bound to see resistance. But if you look at those who actually acquired HIV infection past the first visits on PrEP, very few actually had resistant mutation, only 5 out of more than 176, so less than 3%. So this issue of resistance in people who acquired HIV infection on PrEP is really an issue around acute HIV infection in the first visit. So it's really critical to rule out HIV infection before starting PrEP at the first visit. Another challenge is what to do when you have the patients with HIV infection on PrEP. It's very difficult to handle because, unless this person had discontinued PrEP a month earlier, it's quite challenging and stressful for the patients, for the clinical team. You probably need to start ART immediately. There is no reason to wait with a combination of drugs with a high resistant barrier to resistance, either using a boosted PI or a second generation integrase. You probably can use still TDF or TAF-FTC, but if you're concerned with K65R, maybe you can use AZT, and then you may simplify the regimen once the resistant genotype is available. Anyway, if your patients acquired HIV infection despite the use of PrEP, that means it was probably not adherent to PrEP enough, so you need to reinforce adherence to combine ART. So in summary, I think we know that PrEP now with the oral TDF-FTC, whether you use it daily or on demand, is very effective when taken. And it has a public health impact. And I think this is very important because that's an encouragement to go further and to really fully implement PrEP whenever it is possible, and to make people aware of this new tool. Failures of PrEP are rare. They have multiple causes, as I try to show you in this presentation. And what I think more important is to really rule out acute HIV infection before starting PrEP. It is critical to repeat HIV test every 3 months, but also 1 month after starting PrEP. And the true biomedical failures, as I point out, were actually and are very rare, but they are feared, and we have to learn how to deal better with these biomedical failures. I think I'll stop here. I'd like to thank my group, all our funders and support, and muchas gracias.
Thank you so much for your speech. And is there any question?
Congratulations, thank you for being here. My question is, due to the high rate of false negative results of the fourth generation antibody antigen, ELISA, do you think that it's time to move forward a point of care HIV RNA when we are initially evaluating potential PrEP users?
Yeah, thank you, Jose. I think it would be nice to do that. The problem is the problem of cost and availability. I think, in any case, what you could do is to store blood at the time you start PrEP. So if you can do that, and if at the next visit you found out that the patient had HIV infection, then you can go back and do a viral load and say, well, you have HIV infection on PrEP, but it's not a failure of PrEP, it's because you had HIV infection that was not diagnosed at the time PrEP was started. So that's maybe another issue. I think also, because people coming for PrEP are people usually tested before, that these people may want to be tested with the same assay which was negative before starting PrEP. So using the same assay always, will avoid this kind of false positive.
Can I make another question? Of course. Yeah. No, the second question is, those patients with acute HIV infection during PrEP, do they have any type of symptoms, or are symptomatic seroconversions? So from a clinical point of view, I think it's important. So, and to perform the screening every 3 months is key for diagnosing these cases.
Well, I think we've learned with the PrEP studies that, HIV infection is, as long as you can detect it early enough, is mostly asymptomatic, fully asymptomatic. Some patients may complain of some fatigue or muscle pain, or, of course, if you have a full clinical symptoms of primary acute HIV infection, that's easy. But usually, because we are dealing with people, monitor very frequently, we are diagnosing acute HIV infection very early. So most of the time, it's asymptomatic HIV infection.
And my final question, are you incorporating in clinical practice in those patients who could be bad adherence to the PrEP, tenofovir, TDM, or just this is for...
Well, I think tenofovir TDM could be interesting for daily prep. It's more challenging with on-demand prep. And you know, for MSM, it's approved now by WHO. And how to measure adherence to on-demand prep is clearly a challenge as well. So I think, you know, there are point-of-care tests to measure TDF level, but I think what's more important is not what the patient has done in the past, but what he will do in the future. So I think at every visit, you should reinforce the importance of adherence to PrEP until the next visit. And I think that's what is important. Thank you.
Yeah, Michel, what do you think about the result of the Discovery trial? TAF is better than TDF in PrEP? What is the reason of this result?
Well, I think probably in some rare situation, in people with renal failure or a low EGFR, maybe in these people you might be more comfortable to start with TAF FTC than with TDF FTC, at least with daily PrEP. With on-demand PrEP, we have no data with TAF FTC. There is a recent paper published in GID using TAF FTC in female macaque, showing that TAF alone is not great. The combination is very important. So I think there is also, of course, this issue of cost. I used to say that in France, the cost of PrEP is actually cheaper than condoms. If you go to a public pharmacies where it's only 10 euros a box or 30 pills. So if you use it on demand, 30 pills, you have enough for 2 months. So 11 euros for 2 months is not that expensive. And also what's important, I'll take this opportunity to tell you that because we're doing this, monitoring every 3 months, testing for HIV, for STIs, what's incredible and important to me is that we've seen for the first time among MSM in France last year a decline in the new cases of syphilis, showing that this strategy of test and treat for HIV and STIs is potentially an interesting strategy as well.
Thank you. Any question? Thank you.